All right, it's about 8:01. Welcome, everyone. As anyone's ever been in my class, I like to start on time and end early. But tonight we probably won't end early. We'll probably go the whole hour. So welcome. Oh, somebody else coming in. My name is Victoria Taylor, and I am a licensed acupuncturist in Virginia, and I am sorry, I had to stop the share. I am Victoria Taylor. I'm an ADS and an RT from Southwest Virginia, and I volunteered to coordinate this community connection hour for our organization. Laura Giesler will be managing the tech and monitoring the chat for us this evening. Most of the evening, we will be talking with our panelists, but hopefully there will be time for small group discussion toward the end of the hour. Please stay muted unless you are in a breakout room. If you need to say something, you may use the chat feature to ask questions. Please remember that this is a content-based enrichment presentation and not a membership or business meeting. A full NADA membership and business meeting will be held on Saturday, June 25th as part of our annual conference at Bowie State University. You can look for more information about that event in your emails, and you can register on our website, Acudetox.com. I would like to share our NADA and vision statement. I have asked Tara Moreno-Wallen to read it for us this evening. Let me share that before you read it, Tara. There it is. Sometimes I lose things on my desktop. It's small. All right.
Mission. The National Acupuncture Detoxification Association trains people in the NADA protocol, an ear acupressure and acupuncture protocol for trauma, substance misuse, abuse, mental health, and behavioral health. Together, we promote and advocate for access to holistic health as a right of all communities. Vision. We envision a world where healthcare is people-centered, holistic, and accessible to the most vulnerable and underserved in our communities.
Thank you. And now I'd like to invite Tara to read our principles, because I will refer to them later in the evening.
The spirit of NADA. All beings have a right to self-determination, the capacity to transform and be part of a transforming society. NADA changes the dominant paradigm. Simplicity. The NADA protocol is easy to learn and to teach. Trust. We trust that people are capable of learning and that everyone has the capacity to heal themselves. Person-centered. NADA is a nonverbal protocol that meets people where they are. Sharing the protocol bridges cultural divides. Accessible and barrier-free. Historically and in the present day, there are many barriers to healthcare. Racism, casteism, and all isms are healthcare matters. We work to make the NADA protocol barrier-free and available to all. We believe everyone should have access to receive and learn the NADA protocol. Compassion. We bring an intention of healing to everyone with whom we share the NADA protocol. Community. Healing and recovery happens in community, and the NADA protocol is easily incorporated in diverse settings. We come together across disciplines to promote an integrated approach to healthcare.
Thank you. I always get so inspired when I hear those. It's really a wonderful thing to get to participate in. Now, when I first speak, tonight's program is about medical assisted treatment and Acudetox. When I first began working, it was about 2000 in what was then known as the chemical dependency field. Sobriety was the goal of most treatment programs. The NADA protocol, we learned, was developed as an adjunct and as a substitute for methadone treatment. As the mental health profession began to treat co-occurring disorders, medical interventions for individuals in early recovery became more common. In the last 10 years, medication-assisted treatments have become best practices in most treatment arenas. I am privileged to be a NADA registered trainer, and during the first few days of each training, the students realize that while practitioners of the NADA protocol have become allied with the 12-step programs and other sobriety approaches, their practices include medication-assisted treatment, and so they become confused. And sometimes I do as well. This evening, we will have the opportunity to hear from several individuals who use or study medication-assisted treatment, MAT, or office-based opioid treatment, known as OBOT, OBOT, and discuss ways to appropriately integrate these programs with the NADA protocol. First, I would like to introduce Dr. Khensu Carter. Dr. Carter has credentials as a medical doctor, a master's of public health, a comprehensive acupuncturist, a psychiatric epidemiological fellow, a NADA Acudetox specialist, and a NADA registered trainer. Dr. Carter's resume includes being the co-author of multiple peer-reviewed publications, including the Medical Field's Manual of Best Practices in Detoxification and Substance Abuse Treatment, known as TIP number 45. And he currently is employed as a whole health champion and lead psychiatrist in primary care and mental health integration with the Veterans Healthcare System. And above all, he is truly humbled to have gained the trust and support of the NADA membership to serve for the second time as president of the National Acupuncture Detoxification Association. Welcome, Dr. Carter.
Hi, good afternoon, everybody. Thank you for having me.
Then I would like to introduce Jennifer Phelps, who is an LPN in Lynchburg, Virginia. She works as a certified substance abuse counselor and OBOT outpatient services. Our next speaker, who I don't believe has made it here yet. I got a message that, I'm sorry?
I'm here.
You are, yes, great. All right, Tracy Brannstrom. Tracy Brannstrom is a fourth-year PhD student in an interdisciplinary social science department at the University of Chicago. Her dissertation project explores the rise and evolution of, in quotes, alternative forms of healthcare in the context of the also, in quotes, opioid crisis. Currently, she is reporting on US police reform for National Public Radio. Her research and reporting interests include the politics of healthcare, experiences of illness and healing, substance use, and power structures more generally. All right. Now, the National Institute on Drug Abuse claims that, quote, abundant evidence shows that methadone, buprenorphine, and naltrexone all reduce opioid use and opioid use disorder-related symptoms, and they reduce the risk of infectious disease transmission, as well as the criminal behavior associated with drug use. These medications also increase the likelihood that a person will remain in treatment, which itself is associated with the lower risk of overdose mortality, reduced risk of HIV and HCV transmission, reduced criminal justice involvement, and the greater likelihood of employment. Okay, Dr. Carter, could you tell us about the thesis behind the medication assistant programs for substance misuse, in addition to what that quote said?
Yeah. It's exactly what you just read in terms of helping to preserve life, helping those by way of harm reduction. We're not yet ready for abstinence. To help folks to at least decrease their exposure to toxic substances that they may be using or substances they're using in a toxic manner. and to assist them in maintaining a reduction in that exposure.
Great.
One of the things that I'd like to include in MAT, and I always do, is to include everything that's prescribed in psychiatry, especially. We can consider that medication-assisted treatment. Although the DSM-5, if, say, an opiate is prescribed by a physician within a treatment setting, we're not supposed to refer to abrupt cessation as associated with withdrawal or continued on maintenance as tolerance. That's playing a word game. And virtually even simple antidepressants like Paxil or Effexor, if they're stopped abruptly, we have a cute name called discontinuation syndrome.
Right.
It can be extremely uncomfortable, just
Mhm.
as uncomfortable as stopping a so-called substance of misuse. So, not a protocol has never played those kind of games. We don't have to. We don't have to diagnose because it does exactly what you read. It really helps to help people to help themselves from balancing from the inside out. And with that, that's the essence of how
So
I view
Jennifer,
MAT
what is
and
that?
study.
Thank you, Dr. Carter. So Jennifer, what does that look like at your office? What does an OBOT program look like?
So in our clinic, we only do Suboxone. We have on rare occasions, we have a couple of clients that we will do Subutex with. And that's just the preference of our particular program. We have providers in the area that do methadone, and we will refer them out to those providers. And we work with clients to meet their needs individually. There's enough providers in the area. We're fortunate that we can serve the populations that come in and make sure that everybody gets treatment that's needed. To be able to, we're lucky we're able to refer people out.
So is
And-
that treatment all medication, or is there other services provided in the OBOT program?
We do medication assisted treatment, which is, you know, a part of it, but we actually do wraparound support services. We do cognitive behavioral therapy. We do group sessions with them. Sometimes we refer them to IOP, which is intensive outpatient treatment. And then I also provide Acudetox treatments for them, sometimes individually, sometimes in group sessions, along with meditative music or art.
Oh, that sounds pretty interesting. Thank you.
Yeah.
So it is, in your case, you're at Horizons, right? It's an integrated program.
Yes.
So I remember a quote from Michael Smith that really affected me pretty deeply. And it said that everyone has the right to be drug-free, guilt-free, shame-free, the right to be nurtured with needles and beads, with tea, in 12-step programs, the right not to be categorized. We are all human beings. We are all sacred. So if you have the right to be drug-free, how does integrating medication-assisted therapy honor that vision? I think that Dr. Carter mentioned that it's a step in harm reduction. In your experience, are people being prescribed MAT as a long-term solution or a short-term solution?
A little bit of both. I have some clients that come in with the intent goal to get off of medication assisted treatment as soon as possible. I have other people that look at it as a long-term treatment. It's very individualized. We don't regulate and tell people how long to be on diabetic medication. We don't regulate and tell them how long they're going to be on their psychiatric medications. It's very individualized on the person, on their stressors and triggers. It's based on, you know, how they're doing, what they've been dealing with in their life. Are they engaging in therapy and other treatments? Have they learned other healthy coping skills to help them cope and adjust with coming off of the addiction, whether it be methamphetamines? Do they have co-occurring disorders along with it? There's a lot to consider when you're looking at someone and trying to come up and develop with them a treatment plan.
Mm-hmm. That sounds very, I appreciate all of those considerations. That's really quite a whole person approach, which I think is the goal of many treatment programs and probably has higher results than one that's not such a whole person. I would imagine whole person. So Dr. Carter, do you know how NADA became so closely allied with the sobriety movement? Like if we're in harm reduction, then it wouldn't necessarily be that sobriety was the ultimate goal. Do you think that was a byproduct of the institutionalization of the protocol in the 90s and early 2000s?
Actually, no. I think it's more the reality of what was available back in the late 60s and 70s with regard to what was available to the our patient. Back in the 60s and 70s, there was no medication-assisted treatment other than, say, benzodiazepines with alcohol withdrawal. And of course, it was the 12-step community that's from back in the 40s or so, when they really came together at a time when the medical profession did not want to deal with addiction at all, saw it as a moral failing.
Right.
That's how it got started. So what I really like what Jennifer has said in terms of giving individuals choice. So so it really came about because in the 60s and 70s, at the time when the NADA protocol was the precursor of the NADA protocol was first coming together at Lincoln, there was only a couple gangs in town. Methadone was new on the scene, so the official power structure was really trying to push the methadone as a quote treatment for that, and of course there were the benzos for alcohol, and other than that there was very little attention to a whole person approach at all. That was brand new and something that really came out of Lincoln's function first. Then before it was well articulated, time moved on. So.
Thank you. Yeah, I was noticing that our current NADA mission statement doesn't even use the word sobriety or abstinence. It mentions drug misuse, but in the context of many other conditions. Tracy, do you have any thoughts about this?
Yeah, you sent me this question before, and I guess I was sort of surprised because the question of like the relationship of sobriety to NADA, because the practitioner, the NADA and ear acupuncture practitioners I've been following in New England, mainly in Vermont and New Hampshire, and increasingly I've been following people in Chicago where NADA has to be used in a very underground way because the laws are very strict here in Illinois. I'm in Illinois right now. Those practitioners, doing this they're not integrated into clinical settings. I found that to be like a really hard thing to get access to. So I've been following people doing this very informal work, and they never talk about sobriety or abstinence approaches. They're always talking about harm reduction and, using NADA and other ear acupuncture protocols as an adjunct or an add-on. And they have this kind of philosophy of the treatment's going to be better if you can integrate all these different approaches, whether it's like pharmaceuticals, increasing access to MAT, or Jennifer, like some of the other things that you mentioned. So no, I don't know about like this sobriety history piece, but I just know, in the very particular context in New England that I've been working in, it has never really come up.
The sobriety piece hasn't come up. That's so interesting because in Virginia, I feel like, especially because of our traditionally NADA's relationship to the 12-step programs where sobriety, abstinence is the gold standard, right? The best practice. And then it becomes confounded. I mean, that's my experience here. So it's interesting that it's different in different parts of the country.
Yeah, can I just add something? I mean, I think like what's been so interesting to me and like the analytical kind of thing that I'm obsessing over in my dissertation project is, it's like what I've seen NADA, and I don't just want to say NADA because in Vermont, when I started my field work, ear acupuncture became deregulated, which means that like practitioners they're learning all these different protocols, but like NADA is still very special and important. I have seen them sort of navigating, you know, a lot of NADA practitioners are like MAT nurses, and some of them are doctors and nurses and clinicians and social workers, and like we know this. And I have seen them sort of navigating this tension between, you know, on the one hand, it's like, you don't want to deny that we need to expand access to MAT, methadone, buprenorphine formulations. You know, people are citing the research, you know, public health research, and, you know, I've interviewed like quite a few, you know, people who are in recovery who do say like, yes, it helped me get on my feet. Dr. Carter, you said, you know, or someone talked about balance. So there is that piece of needing to expand access to MAT, while at the same time, you know, there's like, NADA comes out of this like legacy and history and lineage of pushing up against power structures in different ways. It could be medicalization in a broad sense, could be big pharma. And that's the specific piece that I've been really interested in, is like, how are your acupuncture practitioners trying to like navigate, yes, we need to expand access, but how do we do that at the same time that we're like really being true to the mission and pushing up against big pharma as a power structure? And in the beginning, when I started my fieldwork, I was really frustrated by that. I thought of it as kind of a contradiction. I was like, well, which is it? Like, do you hate pharmaceuticals and MAT, or do you love it? Like, but I think I've learned to kind of like lean into that and see that as like a really interesting tension that's like, I don't know, just like a sign of the time that we're living in, and, you know, thinking about like the power of the pharmaceutical industry and how problematic that is.
Well, also, as my husband says, you have to ride the train in the direction it's going. So how do we advocate for our patients and allow them access to what's being prescribed, rather than having them always, you know, and have them be informed, right? Because NADA's place has always been in supporting people-centered and holistic healthcare access. That's our roots. We're in people-centered healthcare access. So why would you deny your people access to current best practices? Right, Dr. Carter?
Well, yes, and I actually even add to what Tracy was saying about what she's observing in Chicago, that the way in which the NADA protocol developed, the milieu in which it developed, the spirit in which it developed, the spirit of NADA, has always been one of a horizontal relationship with patients, not a vertical hierarchy where we have those with the white coats that are coming in and they know best and set the tone of what's happening. At Lincoln, I like to say that still the most amazing acupuncturists I ever saw didn't graduate from high school.
Right.
And they're in Lincoln. Those who were trained were from the community. And I don't know everyone in Chicago practicing, of course, but I think of Francine Caldwell and others there. And I don't have a doubt that they are practicing in a fashion that is only gaining vogue today in terms of peer support. There's a whole tradition of peer support specialists. Right. As a matter of fact, the school where we're going to be having our conference this year prides itself on training peer support specialists at a master's of a level. But for all the degrees, one of the things we know is that they don't make a damn bit of difference. I mean, I'm embarrassed to say as a psychiatrist that in the Journal of the American Psychiatric Association a year ago, it gave themselves a report card based on recommendations they made 50 years ago. And they gave themselves a report card of an F, of having made no progress at all in terms of expanding access, in terms of inclusion, diversity, equity, and accessibility. They gave themselves an F. And so for all the degrees that we get, there is nothing that will replace what is in your heart as a peer support specialist. You or me, I am you. I am here to help and I will do everything I can in that fashion. Anything else is an emperor with no clothes.
Thank you. Jennifer, is there anything you'd like to add to that about working with your patients?
I would say my patients really enjoy having the options of all the tools. They really like having the medication assisted treatment. They enjoy going to AA and NA. They like having MARA available to them as well, which is a 12-step program for medication assisted treatment, which is accepting of them being in medication assisted treatment. We actually have a chapter in our area that we started in Virginia.
That's great.
We're seeing AA and NA start to slowly change their acceptance of medication assisted treatment. So I think the more tools, I think that it's changing to embrace the more holistic care. I don't think one model necessarily fits all, you know.
Yes, thank you. That's I really appreciate that point of view and showing the evolution in the chemical dependency, substance misuse treatment standards. Now, but I have a question. Doesn't MIT create a dependence upon a corporately owned consumer product? Doesn't it tie people into I'm playing with y'all, tie into the pharmaceutical industry, which caused the opioid epidemic in the first place? We talked about that last month. And weren't our ancestors at Lincoln fighting against corporate greed and capitalistic control? So are we like feeding into the hands of the lion by embracing MAT?
Well, the way I think about it is that the world is upside down. And I like to say,
anyway, Khensu, whether we like it or not.
In terms of what's happening today in the contemporary practice of medicine, but I see that changing. I mean, I've always said that if I get hit by a bus, it's not the time to take me to see the acupuncturist.
Right.
I want the best that the Western world can offer. And when you're in the throes of addiction, that's like being hit by a bus. As a psychiatrist, part of my bread and butter is discerning, treating, trying to mitigate, alleviate, intervene, sometimes dramatically and forcefully, folks who want to kill themselves, kill other people. Anybody who knows me knows that's not my style. I'm a horizontal kind of dude. But if somebody is on a bridge, that's not the time to try to negotiate, trying to ask them to step down. You grab them, you snatch them, and help them to have more insight and to help them to come along. So I think that what we saw at Lincoln needs to be in the early days came about in a context that we know they weren't imagining things when they said the government was infusing drugs into the community. They weren't imagining it when they knew the pharmaceutical companies were all on board with that and pushing it. They weren't imagining it when the officials and leaders in the government in New York State were pitted against them, primarily because of a lot of what we see today, even say with the gun lobby. Those who put money in your pockets are the ones you're going to tend to try to represent. And that's what was happening. So the strong stance they took against methadone, I think, is one of context, one of gradation, and that's how.
And maybe we shouldn't just get stuck there.
Don't get stuck there. If you hit by a bus, don't go see your local ADS and think they're going to fix it for you. So.
Jennifer, do you have thoughts about that?
Yeah, I was gonna say, we usually tell clients medication is like 3% of your recovery. It's really the cognitive behavioral skills, changing people, places, and things. It's getting therapy, working through what caused you, your stressors and triggers. We really push all of the other holistic parts of treatment because that's what's going to keep you from relapsing. And so we kind of take it from that approach with clients. And we've actually had a lot of clients come off of medication assisted treatment, taper down and taper completely off. And that was their goal. So I wouldn't say that they're dependent on it, and they don't come in wanting to be dependent on it. They really a lot of them come in wanting to get off. Now, we do have some that want to stay on their medication because to them, they can get up and function. I can now go to work. I got my kids back. I have a job again.
Right.
So to them, it's much better than going out and doing heroin, you know, so it's a better compromise for them. They can function on this and they're not getting high. So
Thank
you know,
you.
for a lot of them, it gave them their life back.
I have definitely seen that many, many times. And I've also seen,
Victoria,
yes, please.
excuse me, Victoria, Ruth had a question. I think that when you finish up, you might want to address her question.
I didn't see the question. What is it?
Well, it's not in the chat. She had raised her hand.
Oh, okay. Could you put that question in the chat, please, whoever raised their hand, and then we'll ask it. Meanwhile, I'll ask Tracy to see if she had anything to add to that about the pharmaceutical industry.
I think the question for me is like, how do we, you know, keep using, like, pharmacological forms of medicine are so important, and how do we continue to value those and use those, and kind of push up against and try to reform a lot of industry practices that are problematic. You know, I think, let's see, I was just looking up some stats about the pharmaceutical industry in the US, and, you know, in 2020, the revenue was 425 billion. I think the pharmaceutical industry is like second most, it turns out it's really hard to answer this question, but is like the second most lucrative industry in the US and or globally. And so, you know, I think there is like an over-reliance on pharmaceutical drugs that's been designed by the industry. Like, that's been really intentional on their part. Social scientists have this really clunky term called pharmaceuticalization. So to say, like, we're living in a pharmaceuticalized society, we have a pharmaceuticalized healthcare system. And there is this, you know, especially in New England, there's this perception that healthcare in America has been kind of captured by the industry, whose primary goals and interests are maximizing profit. And they're not secretive about that. They're very explicit. If you go and look and, you know, read their trade journals, they're not talking about healing people. They're talking about how to maximize profits. So they're not really in the business of trying to reduce illness. And, you know, so while pharmacological medicines, like, yes, I would never say they're not important, but I think it is just important to realize that even the medications that are available to us, and, you know, for a medication to be studied and brought to market by the pharmaceutical industry, that disease category has to be seen as very profitable to them. So, for example, like, the industry is not interested in developing medications for tuberculosis because they just don't, even though people really are still struggling with that disease, they're not interested because they don't see that as a profitable market. So, you know, and I know that methadone and buprenorphine were not, and still are not really seen as profitable markets to them. But I think that's changing, because now that there's a decrease in profits from opioids as painkillers, there are conversations in the industry. You know, if you look at the court documents I'm reading like court documents from these opioid lawsuits for fun and for my research, but you can see that, you know, McKinsey, the consulting firm, when they were consulting with Purdue, you know, you see these like emails where they're having conversations and saying, like, you know, now that there's a decrease in profits from opioids, like, let's really help you to think about how to expand the market for MAT drugs.
Right.
And so, like, sometimes I don't know how to get beyond this. Like, yes, these drugs are important. So maybe it's a question of like how to really think about reforming the industry so that we can have pharmacological medicine at the same time as we can have, like, I don't know, like, less dominant, more ethical, et cetera, kind of power structures.
And also more people like Jennifer Phelps's program that have an integrative approach. I have seen many programs that are just medical assisted treatment with very little support, maybe once a month check-in with a counselor, very large caseloads. And then those patients do just become dependent because they don't have other opportunities. There's another thing about MAT programs that troubles me, is that the drugs that are used have street value. And there are also individuals who if they use street obtained Suboxone or Subutex, then they will pee dirty because that wasn't the drug that was in their court order. And then it creates, and the person next to them in the drug treatment, so they're there because they broke their parole for using Suboxone, and the person next to them is prescribed Suboxone. And of course, this is outside the scope of an Acudetox specialist's job, but it seems to be an inequitable standard and really, really difficult to enforce. And how do we keep people on their programs? We've heard from several clinicians that it's very well, when it's maintained, they have very, very good results. But if it has street value and they need new tires, you know, I think I would sell my Suboxone. So, I mean, I wouldn't, but you know.
Well, I think that, Victoria, speaks to what Tracy was getting at, is that the power structure is more than just the pharmaceutical. Entire power structure from the head on down. And so what part of what we saw at Lincoln is that the intention, part of the intention of methadone euphemistically was activists to sleep. So they would not try to take over a hospital that was administering piss poor healthcare in the community, not addressing lead poisoning in children, not addressing the problems with tuberculosis. I understand that the hospital itself was referred to by the locals as a butcher shop. They had done the legwork of gathering petitions with regard to change. It didn't happen. And lo and behold, through, and I don't think everybody was probably completely clean, but they were woke enough to take over a hospital and involve themselves in self-healing. So from the inside out. So for me, that's where it's been, because other than that, I wouldn't be able to sleep with myself, to sleep at night as a psychiatrist who had only come up in the mainstream for the past 50 years. Speaking to Tracy's point, it's not just the opiates. We learned that antidepressants were oversold and that the initial research for how these things work are often orders of magnitude beyond what they actually do once you look at them. We learned that even as far as children, you know, the pushing of amphetamines and the diagnosis of early bipolar disorder was often done by the ghostwriters at Ivy League institutions that we think of as our leaders. And so I think we need to appreciate that the other message out of Lincoln is exactly how to deal with these sort of power structures. The emperor has no clothes. We keep saying we have no clothes. There are others who are under that illusion. We help to open their eyes to see that they have no clothes. And we continue to try to develop sort of alternative, complementary, integrative approaches that Jennifer is working with in her program, so that we have the alternatives. And so that will help a better order to come about. I don't know another way to do it unless we want to take arms. And I'm fortunate, but I've never had to shed blood. But it sure makes you want to go out and knock somebody in the head sometimes. But the healing is a better path. It's the only path that our ancestors, who we really hold up from Lao Tzu to Imhotep, would have advised us to do. Because without that, you still have to build something, because people are still sick. Detoxing from these power structures is going to be just as difficult as detoxifying from a physical sort of a substance. Our jobs are tied up in it. I like my car and my house, you know, that's going to be tied up in it. So I like the path that Lincoln pointed out for us in terms of that self-healing and developing our own reality that we embrace.
So what I hear you saying, Dr. Carter, is, because my next question was going to be, as Acudetox specialists, what's our role in all this? And what I hear you saying is treat, provide the protocol in all spaces and all places. Is that what I'm hearing?
Well, and the other aspect of early linking was that sort of political education. So the sort of issues that Tracy is addressing should be discussed with patients. It was a deliberate separation of the founders of Lincoln from the protocol. The city of New York got them out of the Lincoln when it was first found, relocated them to treatment programs that did not have that sort of political education, historical education, examining really your community and can we build a better one. They got those folks out. So the sort of things that Tracy is touching on, combined with what Jennifer is doing, is what we need to get back to, because holistic doesn't only mean, I'm meditating and doing mindfulness-based practices and if we're really looking at a biopsychosocial community approach, we're talking about society too and politics.
So Jennifer, anything you'd like to add to that?
Yeah, and I would say, for those worried about the patient end of things, we do a really good job of screening people for our programs before we just let anyone come in and get on medication-assisted treatment. You have to have a diagnosis of opioid use disorder. There's got to be a history there. There's got to be, we vet clients pretty good and making sure that you're right for the program or the medication-assisted treatment is right for you. It may be that you need naloxone or a different type of treatment. It's not that, at least for our program, it's not that easy just to come in and get medication-assisted treatment.
Mm-hmm.
I'm trying to be politically correct.
Stop.
But
Don't
yeah.
do it. Don't do it, Jennifer. Say it.
I know that there are some programs out there that you aren't as strict about the requirements, but most community service boards, that have programs like us, there is a pretty good screening process in place.
That's good to hear. That's good to hear. So, and any advice to Acudetox specialists?
Well, I'll say it as a physician, a psychiatrist who prescribes in many communities, patients know very well who they can walk in the door with and say, this is what I'd like, and they get it. Bam, just like that. I live in Florida. It's notorious. People have gotten, but it's not just Florida. It's around the country and in other places I've worked to. And patients know this. And this is not saying, there's anything wrong with the substance. Which is why I like the idea of substance misuse, because everything has a role. Even poisons can have a healing role if they are used appropriately. But in the hands of a numbnut, even something that is supposed to be safe can become deadly. I mean, the idea of only treating with medications is thinking you can take an alcoholic and dispense Librium or Valium and call that treatment. Some people do that, you know what I mean? But it's not a good thing to do. So, so I feel you, Jennifer. And again, we're going back to direct our ADSs, let them know how the world works. There are snakes out in the world. There are snakes in the grass. Snakes in the grass everywhere. So as much as we can, we should include this sort of conversation and education with our ADSs and RTs just as much as we talk about how to locate 5 points in the ear.
Thank you. Tracy, any final advice or thoughts you'd like to? I'm going to put people into breakout rooms in a second, but I'd like to give you one more chance to address.
Yeah, I think some of the things that were just said just make me think that medicine work and healing at the level of grassroots is so important. It's one of the most important things. That's like really why I was drawn to following acupuncture for my, or not on ear acupuncture for my research. Dr. Carter is talking about, developing alternative, complementary, like integrative, like the alternatives, I guess it's like, it's important to know and to remember that, the pharmaceutical industry, like the very technologies and research infrastructures that they have developed, they sort of, well, first of all, they kind of presume disease as in the domain of like experts and markets, which is really problematic for ADSs because they, there's this ethos of, making ear acupuncture available, like Dr. Carter, like you were talking about, to like, the average person, and offering it for free or very cheaply. But those pharmaceutical kind of infrastructures, if you think about like a randomized control, like how do you do a double-blind randomized controlled clinical trial of something like ear acupuncture or just ear acupuncture more generally? So it's like, even when we talk about research, it's like these infrastructures are designed to privilege, the material molecule and the material drug. And a clinical trial is not successful unless, we're talking a lot about healing. A clinical trial is not successful unless you extract and erase all of the social, emotional, existential, spiritual, what have you, all of these kind of factors that feed into the context of healing, and that's problematic. So,
if I could, Tracy,
yeah,
if I could, in the most recent version of the textbook of psychiatry, they cite a research study that I and my colleagues did as a exemplary example of how to carry out research with the acupuncture and addictions. And the model that I've always suggested, business as usual versus business as usual plus not. That's it. Because in the psychosocial sciences in general, is extremely difficult to have the sort of controls that you mentioned. So you leave everything the same, and the only thing you change is not. I've been I don't know that I've seen ever a study of nada of ear compared to a pharmaceutical. They don't want to do that. They don't even want to do pharmaceuticals compared to another pharmaceutical for the most part. So that is nobody that gets embarrassed. But sort of research to push is business as usual and business as usual plus nada. I can't think of a time when we haven't been seen as positive as an adjunct.
Dr. Carter, is that the article you did in the Journal of Nursing last year?
No, this one is in behavioral sciences.
If you could,
I believe.
during the breakout rooms, put that in the chat so everyone could have access to that. I'm sure it's on the NADA website, and then
Okay.
people want to refer to that. But I'm going to put everybody into chat groups now of 4 to discuss your experiences and thoughts about Acudetox and medication-assisted therapy. Please listen respectfully, as we have much to learn from each other, and everyone comes with a different background. We'll do this for about 9 minutes, and then I have a closing and some announcements.
So please excuse me. I should be back in 9 minutes. I'm going to go look for that article to put the title.
Okay.
Okay. All right.
Hi. Oh, Lita, I need to talk to you after I saw your question in the chat. After everything's over, stay on and I'll talk to you about that, okay? Did you came back, you were in a breakout room? Okay, great. All right. Lost my script. There it is. All right, is everybody back? Room 4 isn't back. There's room 4. All right. Well, welcome back. I really had a good conversation in my breakout room and I didn't even mean to go into one. So I hope that you learned something tonight. I am so grateful to everyone who participated this evening. I'd like to again thank our panelists, Dr. Khensu Carter, Jennifer Phelps, and Tracy Brannstrom. I like to keep it to an hour, but some of us will stay on later if people have more conversation they'd like to have. I want to remind everyone there'll be no Community Connection Hour next month, as most of us will be traveling to Bowie for the annual conference. It is also available as a virtual option. And in July, the Connection Hour will be about the conference. I want to end tonight's program with a musical piece called Ode to Humanity by Empty Hands, which honors each of the communities we find ourselves a part of. And again, I will stay on after the song in case anybody has any final comments.
From the day that we were born, Mom hugged us with warmth, and we grew because we knew we had all your support. From the fams to the friends that love was medicine, keep giving us the strength to rise when we would sin, and the knowledge that we gained through every single mistake. But you never backed down through this, you taught me faith. Every single one of you, through being you, you do find a way to spread love and truth through me and you. And it's because of you I grew, because of you I flew, because of you I made it through without residue, because of you we all have a home to come to. You're a blessing to us all, so keep just being you. To my people, yeah, you're my soul, you're my roots, you're my family, my life, and my truth. To my people, yeah, you're everybody, every being, every life, every moment, everything. To my people, yeah, you're my God, you're my soul, you're the one that pushes me to help me grow. To my people, yeah, I bow down to your heart of gold. Yeah.
First I think the universe, the infinite, the all. Kaja, Allah, whatever name you call. Then I think the ancestors, yes, the predecessors. The wisdom and the knowledge that they pass, solely bless us. Shot the rocket, Sparky, MLK, Malcolm Gandhi. Bob Marley, Michael Jackson, Tupac, they remind me. The power of the pen, the music and the voice. Everything they've done, let me know I have a choice. Down from a people, mom, pop, sister, brother, best friend, acquaintance, lover, co-worker. Even if I don't know you, then you do it. See my way through surface space, make you share it. To my people, yeah, you're my soul, you're my roots, you're my family, my life, and my truth. To my people, yeah, you're everybody, every being, every life, every moment, everything. To my people, yeah, you're my God, you're my soul, you're the one that pushes me to help me grow. To my people, yeah, I bow down to your heart of gold. Yeah. When I close my eyes, I always see learning souls who walk with me. They talk to life, they talk to love. You go to hug when push comes to shove. Turn the cheek, forgive, walk away. Tomorrow is another day. Life is short, helping hands they say. Are holier than the ones who say. To my people, yeah, you're my soul, you're my roots, you're my family, my life, and my truth. To my people, yeah, everybody, every being, every life, every moment, everything. To my people, yeah, you're my God, you're my soul, you're the one that pushes me to help me grow. To my people, yeah, I bow down to your heart of gold. Yeah. To my people, yeah, you're my soul, you're my roots, you're my family, my life, and my truth. To my people, yeah, everybody, every being, every life, every moment, everything. To my people, yeah, you're my God, you're my soul, you're the one that pushes me to help me grow. To my people, yeah, I bow down to your heart of gold. To my people.
Thank you, Nada family. See you in Bowie.